Thank you, Chris, and thank you to the King's Fund for inviting me to present. See if we can get the next going. Yeah. There we go. What I'd like to do over the next 20-25 minutes, and I'll probably talk pretty quickly, is take you on a little bit of a journey. And the journey goes back, at least in my own perspective, to the mid to late 90s, where a colleague and I at Johns Hopkins Hospital came up with this idea for remotely managing intensive care units. And that evolved into a business that ultimately was acquired by Philips, but it brings a perspective, and what I want to show you is how that has evolved from the in-hospital environment into the home now. And so we're going to go on, as I said, this journey. And the journey is really predicated on three major aspects. One is unsustainable trends, which is not a surprise to most people in the audience here. We will have many care needers than we have caregivers. That exists right now, and that is only going to get worse over the next, ensuing 5 to 20 years. And so we have this tremendous imbalance. And whether you look at intensive care specialists or you look at primary care physicians, we just don't have enough. So we need to figure out, how do we provide access to patients that are going to need care in a much more meaningful way. We also provide a double standard of care. And this is basically everywhere I've gone in the world. I could start with the in-hospital environment, where the consultants, I'll use a UK example here, consultants go home in the late afternoon, early evening, and then the registrars are left to run around and do what they think they're supposed to be doing. I was a house officer myself at one point, and we thought that was good training. It isn't necessarily the kind of care that you or your loved ones would want to have. And so, and that transcends even the outpatient environment, where a covering physician might be trying to manage, multiple patients. And so we have to figure out here again a way of bringing quality and access together. And these are data from a bunch of countries, and clearly the trajectory is unfavorable on a cost basis around healthcare. The U.S. obviously leads the pack there, and we're way ahead of everybody. That's not a good thing to be way ahead of, but the reality is that every country in the world is facing the problems of this, ever-increasing cost of care. And so we're left with three major issues, is, access, quality, and cost. And how are we going to deal with that? And I'm preaching to the choir here in many respects, because I see telehealth as being the only way of providing what is necessary. This is an example of the sort of eICU program, which is the genesis of sort of the company. And it's a standard hub and spoke model, but what you see is, from a central core, a group of intensivists and critical care nurses can manage multiple ICU patients across a region, across an entire country. And so what we developed was this software and this workflow redesign to fundamentally change the care model in ICUs. What we have enabled is a leveraging of scarce caregivers. So now one intensive care specialist and 2 to 3 critical care nurses can be managing 130 ICU beds. Well, that's quite a force multiplier, and is no different than what we need to do out on the med-surg floors, no different than what we need to do in the home care environment. How do we get a home health nurse to be able to take care of many, many more patients? Well, the way we've been able to do it is to really do care by exception. And so what that requires is a fair amount of information technology to identify when patients are beginning to trend out of bounds. And what you'll see is that we've evolved this out towards the home environment. So this is what a workstation looks like in one of these eICU centers. that where an intensivist or critical care nurses can be looking at and interacting with multiple patients across a region. This is a map of the U.S. There are 43 eICU centers now around the United States. These are staffed by the local physicians. And so I mean by the University of Pennsylvania, you'll see up there as an example, it's their intensive care specialists, their nurses that are staffing these eICU centers. And so what this represents now is over 300 hospitals and over 6,000 intensive care unit beds, which in the United States probably only accounts for about 11% of the market. We tend to have many more ICU beds than you have here, but you have your HDUs and you're taking care of really sick people on the floors. So fundamentally, people aren't any sicker in the U.S. than they are here. But what this represents is a change in the care model. Has it become standard of care yet? I think we're very close to that, to the precipice there where that's going to be the case. We have some facilities, there's one there in St. Louis, for those that know their U.S. geography, called Sisters of Mercy, that are managing 450 ICU beds across 20 hospitals across 4 states. So, you know, here again, you're not bounded by geography in any way, shape, or form. The value of the program has been demonstrated now in numerous clinical studies. What I have here is an overview. This represents 140,000 patients. This is severity adjusted data using the Apache 4 severity adjustment tool. And what this shows is that if you take a year prior to implementation of the program and then at least a year and sometimes 2 and 3 years following the program, there has been a 20% reduction in standardized mortality ratio for intensive care unit patients and a substantial reduction in ICU and hospital length of stay, which is undoubtedly where the money side comes from. So, you know, you can't have quality without cost reduction, because in this day and age, no one's going to pay for it. There was a recent review done by the New England Healthcare Institute, which is, I won't say they're sort of like the King's Fund. They're more for New England, so sort of a quasi-governmental think tank organization that did an analysis at University of Massachusetts in 2 community hospitals, and you see the data there. And PricewaterhouseCoopers did all the financial analysis, and what they were able to demonstrate was that at the academic medical center and the 2 community hospitals, that their costs were recouped within 1 year. Now, that was multifactorial in nature, but what they were able to show was that by exporting the intelligence from the academic facility out to these community hospitals, they were able to keep patients in the local hospitals that were previously being transferred in. Well, that has dual benefits to any health system. I mean, one, you want to be able to keep patients local. Patients would rather stay local. And more importantly, then, those tertiary centers are not then receiving so many patients that they can't take the ones that they can often do more exotic procedures for, like your recent H1N1 epidemic, where you know, places like St. Thomas were doing ECMO. Well, that's what they should be doing, and they should be receiving those kinds of patients, not necessarily someone who has a community acquired pneumonia. And this New England Healthcare Institute has actually gone to the state legislature in Massachusetts and said that they should mandate tele-ICUs by 2015. Well, okay, so now let's phase shift here a little bit. How do we take this model and extend it across the entire patient continuum? Because that fundamentally, from my perspective, with this care by exception, is what we really need to do. We have developed this concept of a telehealth center. So no different than what I was originally describing to you as an eICU center can now be expanded out. And without going sort of from around the clock here, but if you start at around 9 o'clock, you see that, you know, emergency department, then intensive care unit, then out to med-surg floors, then transitioning into the home, and ultimately in the home covers the entire care continuum, and that a co-located situation, and we have many of our clients now in the United States that are beginning to piece together these telehealth centers are going to be the way we fundamentally deliver care here in the very, very near future. You see down on the bottom left, transfer services and disaster preparedness. Well, those link in very nicely with the emergency department and then case management on the other side. And all of this really supports what we call an accountable care organization. You call it an integrated care organization here, where organizations, providers will be responsible for patient care across the continuum. And it's not going to be transactional payments anymore, where the hospital gets paid and then the physician at home gets paid. They're going to be responsible for the care of a population of patients from, soup to nuts. And if they do it well, they will make money and they will survive. If they don't do it well, then they will cease to exist. And that is where we are moving in the U.S., and it remains to be seen, how quickly we move there, but it is similarly beginning to happen here in the U.K. So that in this co-located center, what you'll have is intensive care doctors and critical care nurses. You'll have home health nurses. You'll have clinical pharmacists. You'll have hospitalists, these hospital-based, floor-based physicians. You'll have transitionalists, which is a new term that I just learned recently. Doctors that their whole role is to transition people from the hospital into the home. Sort of a unique term. And then from virtually, you will have specialty consultants and primary care physicians that are able to access in and then get out to their patients, and I'll show you in a little more detail. From a telepharmacy standpoint, this turns out to be actually a big problem in the U.S., where getting clinical pharmacists to staff smaller facilities is not easy. There aren't enough of them. You can't pay them enough in many respects to be working Saturdays and Sunday nights. And so one of our clients, Aurora Health, that has 11 hospitals, they co-located a clinical pharmacist with their eICU center, and that person was able to do order verification out to a myriad of their facilities. But what they also found was that clinical pharmacist was able to support their intensivists in a meaningful way, going through and changing intravenous to PO drugs, getting rid of double drug therapy. And so they found a huge financial benefit to this. We now have about 10 of our clients that co-locate their clinical pharmacists now with their eICU center. And so here again, if you think about home health, a clinical pharmacist working with a home health nurse around medication compliance, medication questions, it's a huge problem in home care, as we know, relative to patient compliance. On the emergency medicine side, telestroke is really taking off in a big way in the U.S. and I believe starting here. But so these consultants, these specialty consultants, can be accessing through, and if you see the mobile units there, that thing called eCare Mobile, those are positioned in emergency departments whereby a stroke neurologist that is at home or in their office can access into the system, get out to this emergency department wherever it is, write the appropriate thrombolytic orders. That can be a trauma surgeon who can do trauma triage. Psychiatry is beginning to utilize this technology tool, and as you might imagine, putting these in a dialysis center and a diuresis center, which is where heart failure patients are going to start to go more than they go to the emergency department, will be a meaningful way of, here again, maintaining that sort of care model and not just sort of sending them off to a facility where you're not necessarily sure what's going on. We have evolved this out to the med-surg floors, as we call them. You probably call them wards here. And so, as you can see in the upper left, when a patient hits the call button, somebody comes on the screen and says, "Mrs. Jones, can I help you?" And the person on the other side of the screen, they know where the nurses and the nurses' aides are on the floors because they're all wearing RFID type communicators. So depending upon the patient problem, they can get the right person into the right room at the right time. Similarly, we are taking their vital sign data and information from smart beds and smart pumps, and we are running it through a technology that enables us to prioritize messages and only get back to the bedside nurse what he or she, really needs to know about. If you talk to any nurses on the floor, they'll complain they're getting, way too many messages. So we're going to send them only information around critical arrhythmias and smart beds. It says the patient's about to fall out of bed. Their smart pump says that their chemotherapeutic agents stop running. And so here again, bring all the rest of the data back to the telehealth center, where it is then being filtered by humans that can then only get back to the bedside nurses and tell them what they may or may not need to do. This has been ongoing at 2 major sites in the U.S. These are data from one of our facilities. This is a 200-bed hospital that has roughly 120 med-surg beds that are being covered remotely here by this e-hospital team. And while there has been no mortality difference, this is a relatively low acuity hospital. As you can see, the ICU admits have gone down, and those that have gone to the intensive care unit have stayed for a shorter period of time. Similarly, falls have gone down, and most people think it has to do with the fact that when somebody hits the call button, somebody comes on the screen, and instead of the patient getting frustrated and hitting the call button and finally saying, okay, I have to go to the bathroom, and they just get up on their own, not realizing they're dehydrated and have medications on board and they fall, that this is potentially a huge benefit from that standpoint. From a financial standpoint, this health system, looking at their own data, believes that they have saved $40,000 per bed, which doesn't even include new case revenue, because when you get length of stay reduction, you're able to move additional patients through the hospital. Here's where we start to move into the home. I call this lost in transition, because if you saw the Bill Murray movie, this is the black hole of medicine, and I'm probably here preaching to the choir for folks that are involved in home care, because you know that patients leave the hospital and then there's this abyss, and they usually don't have a PCP appointment until some 2 weeks after they get discharged. The readmission peak is between 0 and 10 days, and so you might say, well, what's wrong with that equation? But we all know what's wrong with that equation, and it just doesn't make sense. And so the question is, how do we transition patients more effectively into the home environment? And so we developed this trial that will be starting very shortly at one of those e-hospital locations. And what the goal of the trial is to discharge patients earlier from the hospital into the home environment. Now, why did we do that? Well, because as you know, reimbursement for home care isn't very good, particularly in the United States. And so by being able to reduce length of stay in the hospital, you get the financial benefit. So the hospital is obviously very excited about this for a multitude of reasons. I mean, they're very sort of goal-oriented. So the e-hospital team is going to identify patients at admission that fit these 3 diagnoses that we're looking at: heart failure, community-acquired pneumonia, and cellulitis. And they are going to enroll the patients, and then the hospitalists that are responsible for managing them will know that they're on the track for early discharge. Now, the way we're going to do early discharge is that patients will get education in the hospital, not only around their disease process, but also around the telemonitoring tools that they will be using at home. So for heart failure, as you might imagine, it's going to be the standard, scale: blood pressure, oxygen saturation, symptoms. For community-acquired pneumonia, we are going to add in a point-of-care white blood cell testing device and temperature, because obviously as an infectious complication, part of the reason docs keep patients in the hospital is that they're starting to get better, but they want to make sure they're getting better before they sort of discharge them. And by being able to give them the kind of information that they need and want at home, we believe we're going to be able to rapidly accelerate that process. And for the cellulitis patients, which is a chronic lower extremity infection often, they're going to have the standard plus the point-of-care white blood cell testing plus just a cell phone that is able to send a picture to a dedicated URL. And so that will be the information that will be obtained from those patients. But the hospitalists that were responsible for caring for them in the hospital will be responsible for them until they get handed off to their PCP. And so this is a fundamental change in care delivery, and we believe is not only going to show a reduction in length of stay, a reduction in readmission rates, but really for the first time will, sort of deal with that lost in transition. Here again, just identifying the kinds of information and kinds of training that will be occurring during this, relatively rapid hospitalization period. And will this take a very coordinated effort? Yes, it will. But we believe that we're fully prepared to do this. Now, one of the aspects that I didn't mention on the previous slide is that the home health team responsible for this particular health system normally covers patients from 7 a.m. till around 10 p.m. at night. From 10 p.m. until the next morning, that e-hospital team will pick up the coverage, so that if patients have questions, if patients have concerns, 24 hours a day, 7 days a week, they will be able to access a clinician, and then whether it's the e-hospital team or the home health team, they will be able to get to the hospitalist who discharged that patient from the hospital and has a vested interest in making sure that that patient obviously gets the most optimal care and doesn't come back to the hospital. This is a picture of what you might imagine to be the Philips product line around home care, and most of the items on the bottom you're probably familiar with. The thing that looks like a coffee pot is actually an electronic medication dispenser, which enables you to know that the patients took the drugs out of the little packet. You don't know whether they took them, but you know they took them out, so by proxy the assumption is that they actually did ingest them. On the bottom right there is the point of care testing device, and the upper left is Motiva. What we are now working on very aggressively at Philips with the home health team are these multi-parameter algorithms. And this came out of our work within the intensive care unit, where we have multiple different data points coming in, and we have developed algorithms that look at 35 different parameters, so to speak. And so my assessment, probably back about a year or two ago, was that most of the home health, when I looked at the GUIs, whether it was the Philips product or anybody else's, sort of looked at individual variables, weight and blood pressure and stuff. And that isn't the way clinicians think. That isn't the way human physiology works. And in many respects, it was a little bit short on symptoms. And any doc will tell you that 90% of your diagnoses are going to come from your symptoms. And so by bundling together symptoms and physiologic variables, we believe we can identify more upstream clinical deterioration. Now, this remains to be proven, but it seems rather intuitive that a combination of these individual variables into a multi-parameter algorithm, and I'll use heart failure as an example, that would be different from a New York Heart Association class 2, 3, and 4 type of patient, obviously would need to alter those accordingly, will be able to be much more predictive, and you'll be able to get to the patient in a much earlier time frame than maybe an emergency department visit. So bundling this in together here again and coming back to the original sort of model, that intensive care unit model, where care by exception enables one intensivist and multiple critical care nurses to care for a large population, we are moving towards that similar model in the home environment. And so that using these multi-parameter algorithms, we believe, and our little lady up there in the upper left, who doesn't look terribly chronically ill, but she's our chronically ill woman, she will be entering her information in, and the database may actually come back and ask her some additional questions, because she might turn out to be on the cusp, and so we need a little more information. And then based upon her inputs into this smart alert engine, it will output then red, yellow, green, and many patients will hopefully be green, and that only the reds and the yellows would be the ones that the home health nurse would need to obviously call and get back to. And this other technology that I talked about earlier called Emergent will outbound a message to the PCP in whatever form he or she wants to receive it in. And so, here again, making as technologically seamless the communication from the patient through the telehealth center and then to the PCP in a meaningful way. Lifeline, if you're familiar with that, is also a Philips US-based product that sort of started with these pendants. I fell and I can't get up. A bit older. Actually, my parents have. And so that we're going to interdigitate Lifeline with that, because this is a very high-tech solution, but patients also want high touch. And so Lifeline, by incorporating them in, even if somebody's, let's say, green for a whole week, well, you can't just let them go, so to speak. And so we need to communicate with that patient and make sure that they know we're still looking after them, that there is still somebody out there that is trying to motivate them in a meaningful way. And so we think that the combination of high-tech, high-touch is really what patients ultimately want. And so where's this all going? Well, we believe that obviously people will be downloading their data in a much more rapid and voluminous fashion. Home health will turn out to be the intensive care of the world in many respects, because patients won't just be entering their physiologic data once a day or twice a day. It will be downloaded continuously, and so being able to deal with reams and reams of this kind of data, is something that we've been doing for a long time, because ICU patients, as you know, are continuously, like every minute, there's tremendous quantities of data. The wristwatch is the new Lifeline that has a chronometer in it, and that not a chronometer, an accelerometer that will identify when someone has fallen. So, oftentimes elderly people have fallen and then they're either unconscious or the pendant goes flying across the room. This will identify it, and then we'll be able to communicate back that there is a problem if the patient doesn't call in. Smart houses, as you know, are being developed, whether there's cameras in certain rooms looking for patterns of movement and or beds that are sending vital signs on a continuous basis. GPS devices will be implanted or applied to Alzheimer's patients so that you'll be able to track them. I understand there's a project somewhere in the London area where psychiatrists are using it for a group of psychotic patients, where they're able to track their location. And you might say, well, this is Big Brother, and to a certain extent it is. But where is all this information going to go? You could say it could go to your ADT security system, and that might be one location. But I think that this information will be coming back to a health system, an integrated hospital network, telehealth center that will then be responsible for managing patients across the entire continuum. And we're getting very close to realizing this right now. As you sort of heard, we've got bits and pieces of it, and we're looking to put together a telehealth center probably in 2012 that encompasses the entire patient continuum. So this isn't Star Trek. And when I started back in 1995 and we talked about taking care of patients in the ICU remotely, people thought that was heretical. Well, it's this close to being standard of care in the U.S., and we're hoping to have our first facility in the U.K. very soon. And so this is near term, and thank you very much for your time.
Ryan, thanks very much. We'll take 5-10 minutes for some questions, then we'll move on to David, our second keynote speaker this morning. Somebody once said, I can't remember who it was, the future already exists, it's just not equitably distributed. And that's part of what I think we've been hearing today. Can I just ask a question about the way in which you can get the best use of some of these innovations in technology, and how far it depends on working within the integrated systems that you referred to right at the end of the presentation? Because much of it must depend on having aligned incentives within those systems to justify the investment in one part that realizes the savings in another part.
Yes. Undoubtedly, the movement towards these integrated, I mean, in the U.S. we have large integrated delivery networks right now that are provider-based, primarily hospitals, but they're buying up physician practices as we speak. And actually, for the first time, there are more hospital-owned physicians in the U.S. than there are private practitioners. And, in many respects, the government really sort of likes that, because here again, you have aligned incentives between your two provider groups. It is extremely important for, to your point, Chris, that an organization understands that they have a responsibility across the care continuum. I mean, our success to date has been in the integrated delivery networks that believe that they need to leverage their intensivists across multiple facilities, but to move into these more, to go from the hospital to the home truly requires that they believe that their level of responsibility transcends the hospital walls and gets out into the home, which it undoubtedly does and will.
Yeah, and therefore the challenge for us, this is probably an unfair question, in which case you can duck it, is with our system in England, where we have hospitals run by one set of organisations and community services by another, and then GPs are somewhere over there and social care is somewhere over there, we're not ideally placed to realise the benefits of this stuff, are we?
Not yet, but my understanding is that there is a coming together of those organizations also. While it may be somewhat theoretical at the moment, there will be practical examples of that, I think, that will evolve. And really if you think about the way care needs to be delivered, if it's not coordinated, we'll end up with what we have right now, which is just silo-based care that lacks adequate interoperability from a technical, but more importantly from an operational standpoint.
Yeah, absolutely right. I'm sure we'll hear more about this with David's presentation too. I saw a hand in the middle over there. The microphone's on the way to you. And if you do want to come in, put your hand up. I'll bring 2 or 3 colleagues in. Gentleman here next. Please say who you are.
I want to do only a simple question. Who is the owner or the customer for all this? Where the organization or person or
right.
that you intend to sell all this technology?
The customer is the health system, so it's the hospital CEO, chief medical officer, but it's also the clinicians, and it really requires a dual sales process, because even though physicians and nurses are becoming much more hospital employees, they still need to buy into the concept. And so, but fundamentally, the person who is writing the check is the health system.
Okay, and there's a gentleman there next.
Well, I was David Hogarth. I'm Westminster Local Involvement Network. Of course, I was delighted to know that somebody might come through to me and say, David Hogarth, your sugar levels are too low this morning. Why didn't you take your glycoside? But could we not extend this? And this is really a question. Is it possible to have telesocial care as well? And I don't mean just falling down. I mean that have some sort of device which would measure the bodily correlates to depression, for example, and say, look, you're feeling blue this morning. What can we do to help?
This is the big brother.
The color blue is a little no. I'm not aware of any particular device that is able to sense one's level of depression. I can tell you that even a simple pedometer of sorts that looks at at movement can be used as a proxy for psychological conditions, in that if somebody is not getting out of bed, to your point about depression, and there's no movement on their pedometer, you might make that leap and call into that patient to actually ask that question. So while I think we're going to be left with proxies of sort of behavioral changes, but ultimately I'm sure there will be the depression monitor.
Can you produce it?
In time. Let me get
I'm sure there's somebody in Philips working on it now. But.
Okay.
Hello, my name is Paul Rice. I work in the NHS in Yorkshire and Humber. It was a very compelling vision from a professional perspective. I just wondered, culturally, where the patient and user comes into this mix, because there's a lot of compliance and a lot of sense that they're responsible across the care continuum for the life that they live.
Clearly, the patient has to be, and I would contend, and I've told people even when they're in the hospital, that they need either to have their own control or some healthcare proxy that is working for them, because there's a level of responsibility that patients need to take if they want to be safe in many respects. As you get into the outpatient environment, that only goes up dramatically. The patient in that lost in transition trial, clearly satisfaction is going to be a huge component of that, because we need to assess whether patients want to be discharged early, whether they like this level of care, and I know that obviously in the whole home care arena, that patients' responsibility and motivating them is a huge issue, and so it needs, to your point, it needs to be an integral part of this. How you develop these systems that actually put some level of responsibility on the patient in a sort of a less obvious way, but motivate them is one of the great challenges. I mean, I think that Philips has done a very nice job with some of their Motiva products, getting the patient engaged in their disease process and being motivated, but that's a start, and we really need to do much more. So I mean, it's a huge problem that needs to be dealt with.
So we'll take two more. There's one in the middle, and then I'll come to Jen.
David Dawson. I have a background in intensive care as well, and it's a fascinating vision you have there. It struck me, though, as a clinician looking after 130 patients, that has the prospect of being quite exciting at times. And when you started off, we were talking about the two standards of care, the week and the nights and weekends. Being that intensivist looking after 130 patients at 4 o'clock in the morning also sounds even more challenging because of our diurnal rhythms. But with this, you could have, right now, it could be in the UK, that site looking after your American patients. Do you foresee that happening? Because then you've got somebody at their peak performance looking after them.
I mean, emergency department physicians have been working sort of diurnal shifts for 20 years. And it's the kind of thing that most of the folks do a week in a row, or at least 4 days in a row. And one of your colleagues, you may know Richard Beale, he's sitting over here from St. Thomas. He's been to one, he's seen one. He's very interested in having one. We're very interested in having it. It really isn't very challenging. And the fact that with a click of a mouse, I could be anywhere in the UK in a matter of seconds to a patient who has absolutely zero access to a well-trained intensivist. And so, in many respects, this isn't a vision. I think the vision showed up on maybe the last 2 slides. This is reality, and this is being implemented right now across the United States. There are 2 facilities outside of the U.S. that are delivering care back to the United States. I won't identify the countries that they're coming from, but the world is flat, and we could cover you here similarly. I mean, it really doesn't matter. The problem that we have is that we don't have enough well-trained physicians and nurses to be able to deliver care to this ever-growing patient population. And so I think you're going to see it here soon.
Last question, coming remotely, I think.
Coming remotely, yes. It's from Nicholas Mello, who asks, does the restructure of the NHS make the UK a less or more attractive market for Philips system? And then just tagging on to the last question you had, what strategies are used to ensure professionals are learning how to use the equipment efficiently?
To your first question, I believe that the fact that the NHS has sort of divested into different trusts is probably beneficial in that the trusts are now more like integrated delivery networks that can function somewhat autonomously and can implement at least the eICU program, and then all these other things just sort of are appendages on that infrastructure. I forgot your second question.
Training of staff.
Oh, training, yes. It turns out that it's pretty easy to sit down at one of these consoles of sorts, and because it's very much what at least intensive care physicians do. I mean, they're constantly multitasking, and they're getting called from patients that are on a different floor or by a nurse that's on a different floor. And so here again, it's a much more efficient way of delivering care. I will tell you that there is absolutely no sound in an eICU. Alarms have been totally removed because everybody sort of, I mean, you drown them out anyways, and nobody pays attention to an alarm in an ICU. So it's all visual cues. The training is actually pretty straightforward. It usually takes about 4 to 8 hours for an intensivist to actually feel comfortable being able to use the software and deliver care.
Brian, thank you very much. Let's show our appreciation again.